Patients come to ENT OP or ER complaining of ringing sensation in the ear or hissing sound in the ear, and that is called tinnitus. So today's class is on tinnitus because it is important both undergraduates and postgraduates, as they may get a short note, or you have to manage the patients in your OPD. And also this tinnitus is an area which is open for research. The evidence regarding the cause of tinnitus and also investigations needed and also the treatment of tinnitus, there is very less of evidence regarding this. So if you are interested in research, you can start doing on this tinnitus. So I will explain tinnitus under the headings of definition, causes, pathophysiology, investigation and treatment. Okay. So this tinnitus is actually a Latin word. This was the Latin word meaning to ring. Okay. So it is actually a ringing sensation, ringing sound in the ear, and this was described in 1240s. Okay. So that means this is as old as mankind, or even before that this tinnitus was there. And so many famous artists and physicians were suffering from this tinnitus. Beethoven was suffering from tinnitus and deafness from the age of 28, and he suffered it till the end of his life. And another person from England, that is Joseph Toynbee, he was known as the father of otology from England. Okay, father of otology. And actually Joseph Toynbee was suffering from tinnitus. So he was fed up with that, and he started on research on that, and he himself made a Valsalva insufflation with chloroform and prussic acid as a treatment of tinnitus, and it was so fatal that he became the martyr in the field of tinnitus research. Okay, so that is tinnitus. And how can you define tinnitus? So definition of tinnitus is important. There are three parts for tinnitus definition. One is there should be a ringing sensation in the ear, okay, for more than 5 minutes. So ringing sensation in the ear for continuously for more than 5 minutes without an acoustic or electrical stimulation of the ear. Okay, so without acoustic bar electrical stimulation of the ear, and not immediately after an exposure to loud sound. Immediately after exposure to loud sound. So all these should be there to call it as tinnitus. So it should be ringing sensation in the ear for continuously for more than 5 minutes without an acoustic or electrical stimulation and not after exposure to loud sound. Then you can call it as tinnitus. Okay. The causes can be, actually there are two types of tinnitus. One is subjective, that is heard by, the sound is heard only by the patient, or it can be objective, that is the sound in the ear can be heard both by the patient and also by the examiner. Okay. And before that, coming to the epidemiology, the tinnitus, the prevalence is actually between 15 to 32%. 15% is reported from UK and 32% is reported from United States of America. And most of the patient will not complain this. And if you can evoke the complaint, or you can get the complaint only if you ask open questions to the patient. When the patient comes with some hearing loss, if you are asking, are you hearing any other sound in the ear? Then the patient may tell you that I am hearing. Otherwise, the direct reporting is very much less. So the prevalence is actually underestimated than the actual one. So you can tell it as 15 to 32%. Okay, and this is seen more in females than in male, and there is a connection between the melanin, presence of melanin and tinnitus. So this is seen more in blacks than in white persons. Melanin content is thought to be a reason for tinnitus. And also the prevalence increases with hearing loss. That is why in older persons with presbyacusis will complain of tinnitus more commonly than persons with normal hearing. And this is seen as this has got an association with a higher socioeconomic class. Okay, this is seen more commonly in the left ear than in the right ear. Okay, so 15 to 32%, more in females than in male, more on left ear than on right ear, more in higher socioeconomic class, and more in blacks than in white, and also associated or more in association with the hearing loss. Okay, so coming to the causes. The subjective tinnitus is caused by so many reasons. Subjective tinnitus has got an association with the ear diseases. Usually sensory neural hearing loss is more commonly associated with tinnitus, and mainly the noise induced hearing loss, both acute and chronic. Acute noise trauma and chronic noise trauma, and acute noise trauma is more commonly associated with the tinnitus. Okay, and also Meniere's disease has got a very high association, or the prevalence of tinnitus is increasing with the Meniere's disease. Also can seen with the vestibular schwannoma, presbyacusis, sudden sensory neural hearing loss, and also with conductive hearing loss, like secretory otitis media. In children, one of the commonest cause of tinnitus is secretory otitis media. Okay, and it is also associated with the subjective tinnitus is seen with neurogenic disorders, then bone and joint disorders, then endocrine to other metabolic causes. There is high prevalence of tinnitus in persons with a long-standing diabetes mellitus. Then temporomandibular joint dysfunction, cardiovascular disorders, and also ototoxic drugs. Ototoxic drugs you have to remember. Usually the main association with the tinnitus is seen with the salicylates and quinine. Okay. Usually asked as a MCQ. So ototoxic drugs which causes tinnitus, salicylate, quinine, and also aminoglycosides like kanamycin and neomycin, and loop diuretics like furosemide, and also anti-cancer drugs, cisplatin. Cisplatin is an anti-cancer drug which causes tinnitus. So salicylates and quinine are most commonly causing tinnitus, and also aminoglycosides like amikacin and neomycin. Then cisplatin is an anti-neoplastic drug, and also loop diuretics like furosemide. So all these are causes of subjective tinnitus. And what is this objective tinnitus? I already told you. It is tinnitus heard both by the examiner and with the patient. Okay. So one of the main reason for an objective tinnitus is vascular tumors. It will cause a pulsatile tinnitus. Okay. So coming to the causes of objective tinnitus. Reasons for objective tinnitus. Don't confuse. These are the reasons of objective tinnitus. It can be vascular tumors. It can be both vascular tumors, can be both arterial and venous. So arterial or venous tumors will cause turbulent blood flow. So there will be sound which can be heard by both the patient and also by the examiner. Usually it is heard as a pulsatile tinnitus. Okay, so pulsatile tinnitus. So it can be by glomus tumors, both glomus jugulare and also glomus tympanicum. Then hemangiomas. Another one is arteriovenous malformations, aneurysms, fistulas, stenosis, and also increased intracranial pressure will cause a pulsatile tinnitus. And also transmitted cardiac murmurs will cause pulsatile tinnitus. And hyperdynamic vascular state, in which condition You can get a hyperdynamic vascular states in pregnancy, then hyperthyroidism, and also in anemia. Okay, so in all these conditions it will cause a hyperdynamic vascular state causing a pulsatile tinnitus. Okay, so vascular lesions like glomus tumors and hemangiomas, AV malformation, aneurysm and fistulas increase intracranial pressure, and transmitted cardiac murmurs can be heard by as tinnitus, and hyperdynamic vascular states, all these will cause pulsatile tinnitus. And myogenic causes. What is that? Myogenic. That is the way an abnormal rhythmic activity of the muscles which are related to the auditory system. This usually it is heard as clicking or a twitching sound in the ear. So which all muscles are closely related to the auditory system? One is palatal muscle. So one of the commonest cause of an tinnitus is palatal myoclonus. Okay. And also there are two muscles within the middle ear. What are they? It is tensor tympani and stapedius. You have to study the video on contents of middle ear. Okay, so there are two muscles which is stapedius and tensor tympani. So tensor tympani and stapedius myoclonus will be presenting as a tinnitus. Okay. Another one is patulous eustachian tube. In patulous eustachian tube, there is atrophy of the mucosa of the eustachian tube or muscle dysfunction within the eustachian tube. So this eustachian tube remains open. So that what will happen? With each respiration, there will be a to and fro movement of the tympanic membrane. In normal condition, remember, in normal condition, eustachian tube remains closed. When you swallow or you yawn, this eustachian tube will open. At that time only there is a balancing the middle ear pressure with that of the atmospheric pressure. Usually it is closed. When there is a mucosal atrophy or when there is muscular dysfunction, this eustachian tube becomes open. It is remaining open, so that leading to a patulous eustachian tube, and with otoscopy you can see the to and fro movement of the tympanic membrane in respiration. And also if you do an tympanometry, you can see fluctuations in tracing. Complaints of patient will be a blowing sound in the ear, or there will be patient can hear the sound of respiration or heartbeat, and also there will be the patient's own voice will be reverberating. Okay, so that is patulous eustachian tube, another cause of objective tinnitus. Then another reason is temporomandibular joint dysfunction. Okay, so 1, 2, 3, 4 is TM joint dysfunction. This can cause both objective tinnitus and subjective tinnitus. Another one is spontaneous autoacoustic emissions. You know what is autoacoustic emissions? There are different types of autoacoustic emission. There are high levels of spontaneous autoacoustic emission which are above the audible level of the patient will lead to an objective tinnitus. Okay, so these are the causes of objective tinnitus. So I explained subjective as well as objective, right? Coming to the pathophysiology of tinnitus. This is the auditory pathway. It was explained in detail in a class on physiology of hearing. Please see that. I have given the link in the description box. So I just summarize that. So this there are efferent system and there is efferent system. Efferent from cochlear to the auditory cortex, and efferent from auditory cortex to the cochlear level. So this outer hair cell and there is also inner hair cell, and this outer hair cell is mainly activated as a mechanoreceptor transduction system, and this will stimulate the inner hair cells which are the true auditory receptors. So from the inner hair cell, this mechanical stimulation is converted to electrical signals. They are going through to the cochlear nucleus through eighth nerve, auditory nerve, and from here starts the central auditory pathway. So from the cochlear nucleus, mainly the contralateral stimulation of this superior olivary complex, lateral lemniscus, then internal colliculus, then from there to medial geniculate body and to the cortex, and also there is an efferent system from the cortex to up to the inner hair cell. See, these are all forming a network loop. A feedback loop is formed for the auditory system. Feedback looping. So, any spontaneous aberrant activity within this auditory system will be presenting as tinnitus. There are both excitation potentials and there are also inhibition potentials. These excitatory and inhibitory signals should act in a coordinated pathway. So, if any blockage or hyperactivity or hyper depression or hyper disinhibition of this loop, this feedback loop will cause a tinnitus. So, what are the causes of tinnitus? I will explain. So, one can be at the cochlear or at the peripheral level. Okay. So, cochlear level, or another can be at the central level. Right? At the cochlear level, what all things can happen? Any destructive lesions of the cochlea, that is one. The lesions can be either a structural cochlear damage or spontaneous cochlear oscillations or eighth nerve damage or any tumors of the eighth nerve, or can be a glutamate excitotoxicity. The glutamate is the main neurotransmitter in any mammalian central nervous system. Okay, so when there is an excitotoxic levels of this glutamate, again this can lead to tinnitus, or there can be alterations in NMDA. What is that? N-methyl D-aspartate. N-methyl D-aspartate or non-N-methyl D-aspartate receptors. They are all at the peripheral level or at the efferent level. Then at the central level, there can be either a vascular loop or tumors. The report will come as ICA, anterior inferior cerebellar artery vascular loop in patients with tinnitus. So, vascular loop or tumors or extra lemniscal auditory system activation. In sometime the tinnitus will be provoked by jaw movement or gaze fixing will lead to tinnitus. That is the reason for extra lemniscal auditory activation or reorganization of receptor surface in the primary auditory cortex. All these will cause some changes in this feedback loop, and when there is either at the peripheral level or at the central level, all these causes will lead to spontaneous firing, or there can be inhibition or excitatory changes in the feedback loop, and this will cause release of some mediators like serotonin or dopamine, or they can be noradrenaline. Okay. So, this along with the presence of stress or any psychological problems, stress related or severe mood variations will lead to this tinnitus. Okay. Production of tinnitus. Right? These are the proposed causes or the proposed pathophysiology for tinnitus, though it is not fully established. Okay, there is not of much, I already told you, not much of an evidence for correct pathophysiology, investigation and treatment of tinnitus, but these are the proposed theory behind this. So, lesions at the peripheral level or at the central level will cause changes in the excitatory or inhibitory feedback loops, which will lead to release of mediators like serotonin, dopamine or noradrenaline, and if it is related or there is presence of some mood variations or stress, all these will eventually lead to tinnitus. Okay, so that is the pathophysiology. This investigations. Okay. What all investigations we have to do in a patient complaining of tinnitus. So, high level of clinical suspicion and an individual approach to each patient is needed, because the cause and also the pathophysiology, everything will be different in a young patient and also in aged patient associated with presbyacusis. So each patient, the investigations will be different. Okay, but in general you have to ask one for history. You should be a very good listener. You have to make the patient talk. Okay, ask him what is the subject, what is the type of tinnitus, or subjective description of the tinnitus is needed. Okay, subjective description. Make the patient describe his difficulties. Description, so that you can know whether it is making an annoyance to his social life, his professional life, and also for sleep. Okay, sleep pattern and daily life. Then you have to ask for any associated auditory and vestibular symptoms like vertigo or a hearing loss, like that. Okay, auditory or vestibular symptoms. Then you can ask for, is the patient is taking any drugs. I already told you so many drugs like salicylates, quinine, like that. Okay, drug history and also medical history. Any comorbidities associated, and also you have to evaluate for any existing or past history of any psychological problems, mood variations or stress related, like that. Okay, so all this has to be very clearly asked in the history. Then in the medical evaluation, I already told you in the along with the causes, there are so many cardiovascular, metabolic, then joint related. All these problems can cause a tinnitus. So medical evaluation has to be done, especially the baseline biochemical and also the hematological investigations, and also syphilis serology and autoimmune assessment of the patient has to be done. And in the neuro-otological evaluation, one you have to do is an auditory evaluation. For that, do an otoscopy to visualize the pathology. Then do an Puritan audiogram and tympanometry. Puritan audiogram is to find out the sensitivity of hearing. Then tympanometry and stapedial reflex. That is to know the middle ear. Tympanometry is to know the middle ear status, and stapedial reflex to know the whether there is any pathology in the afferent and efferent arc of stapedial reflex. Again, this tympanometry and stapedial reflex was already explained. Please go through that. And also Puritan audiogram. How to do a Puritan audiogram? Everything related to Puritan audiogram was already explained. Then go with an assessment of or measurement of autoacoustic emissions. I already told you the spontaneous autoacoustic emissions itself, it is high level, above the audible level, it can cause an objective tinnitus. Okay, so autoacoustic emission, you have to go for an spontaneous autoacoustic emissions, evoked autoacoustic emissions, and also olivo-cochlear suppression test. You have to do an olivo-cochlear suppression test also. Right? And also go for an auditory brainstem evoked response audiometry. That is to find out whether there is any pathology in the retrocochlear level. Right? So auditory brainstem evoked audiometry. Right? So under auditory comes all these. Second is the vestibular assessment. Detailed assessment of the vestibular system, because vestibular nerve schwannomas will again may be a cause of this tinnitus. Then go with a cranial nerve examination, CNS along with the cranial nerves. That is very important. And next is imaging. Okay, so under imaging, the gadolinium enhanced MRI scan is the investigation of choice to find out the any pathology which causes a tinnitus. Okay, so gadolinium enhanced MRI and also fast MRI is needed, and if you find out, if you suspect any soft tissue tumors, also go for a contrast enhanced CT scan of temporal bone and also posterior fossa. So under neuro-otological evaluation, think of the auditory, vestibular, CNS and cranial nerve, and also imaging. Next is authentication of the presence of tinnitus, that is test to identify and quantify tinnitus objectively, and that is very essential or crucial in the treatment of tinnitus. But such a type of tests are not available at present, because this tinnitus is purely subjective phenomena. So some test to identify and quantify tinnitus is under trial, and they are, one is matching of loudness and frequency of tinnitus, that is we are matching the loudness of tinnitus with that of the pure tone or narrow band noise, and also the frequency of tinnitus is matched with that of the narrow band noise. Okay, and also tinnitus maskers and inhibition of tinnitus, that is temporary or long-term suppression of tinnitus. So under authentication of presence of tinnitus, all the these three tests are under trial only. Okay, and another one important one in the investigation is psychological profiling. Psychological profiling by using multiple questionnaires. This is important in the assessment of tinnitus, because there is psychological reasons or psychiatric reasons will cause. One is functional imaging. In the investigation, mainly comes the fast MRI and also PET scan. But these two are in the early stage of development as an investigation of tinnitus. So adequate history, medical evaluation, neuro-otological evaluation, then authentication of the presence of tinnitus, psychological profiling and functional imaging are the investigations done for tinnitus, and also to find out any underlying cause. Then what about the treatment of tinnitus? Review of evidence shows that there is no effective treatment, or there is no well-established treatment plan for tinnitus. But we are trying multiple treatment modalities. So I'll write the summary of treatment plans of tinnitus. So as I already told you, there are multiple modalities of treatment for tinnitus. The most commonly used one is pharmacological or medicines, antidepressants. Before this, you have to remember the pathophysiology, that multiple feedback loops and spontaneous activity, counteracting this excitatory and inhibitory feedback loops, that you have to remember. So antidepressants like amitriptyline or nortriptyline can be given. GABA analog like alprazolam can be given. Glutamate receptor antagonist caraverin is also effective. Then calcium channel blockers like nimodipine can be tried. Anti-epileptics carbamazepine and also sodium valproate can be given in tinnitus. Then prostaglandin analog misoprostol is also effective. The most highly effective drug is lidocaine. Multiple research trials are going on lidocaine. They are giving it as a local injection into the nasal turbinate, and also intratympanic injection of lidocaine is found to be effective in many trials, the trials are going on. So all these are the pharmacological or drugs that can be given in tinnitus. The second one is psychotherapy. We can also try psychotherapy, that is mainly the cognitive behavioral therapy, CBT, that is mainly to identify and dispel the attitude, fear and stress of the patient in relation to tinnitus. And the CBT is because of the COVID times, the internet based CBT is also now in practice. We can also give biofeedback sessions, relaxation techniques and also stress management, because all these because stress and all psychological problems are got a direct relationship with the tinnitus. Then in the instrumentation, mainly hearing aid, especially in old age patients with hearing loss. You might have noticed that patients of presbyacusis will be complaining of tinnitus also. So if you are giving hearing aid, there is a very high rate of recovery from tinnitus in old patients. But hearing aids are of a very limited value in children. Okay, in children the treatment is almost the same as at an adult. In children we give more of a psychotherapy, and hearing aids are of limited value. Noise generators are instruments which produce noise, and they can be kept as a hearing aid behind the ear or in the canal. Noise generators are available. Tinnitus instruments are a combination of hearing aid and noise generators. Okay, and this there are pillow speakers. If the patient is having very high levels of noise at sleep time, and they cannot sleep at all, then you can prescribe sleep pillows. Pillow speakers are there. Then FM radio mistuned, it will produce a sound which will mask the tinnitus also. And tinnitus retraining therapy, also electrical and magnetical stimulation of the cochlea or transcranial cortical level, and also herbal medicines, mainly ginkgo biloba, can be tried. All these are under trial. And the thing is, whatever the treatment, you should have a very empathetic and soothing attitude to the patient. So listen to the story of the patient in detail. Be a listener, and then do a very clear medical examination, not only as an otologist, but do a medical examination as a physician. After that, do the necessary investigation. I have already explained the investigation. Do the necessary investigation depending upon the patient, and explain the investigation results to the patient in a very soothing and in a simple terms, and also give treatment options to the patient and reassure the patient. That is also very important. So I have explained tinnitus in detail. That is, you know the definition. I already told you that continuously for more than 5 minutes, not because of there should not be any acoustic or electrical stimulation of the ear or acoustic system or the auditory system, and not immediately after and sudden exposure to loud sound. Then you know the causes, pathophysiology, investigation and treatment. Because tinnitus tinnitus makes dilemma in the investigation and treatment of both the patient and also the otologist. It's a difficult to manage situation. So all this will help you to manage that difficulty. Thank you.